Good day, dear colleagues. This is Dr. Jihad, and our today's lecture is a continuation to the series that we have started, What Surgeons Should Know. And today we are going to talk about rectovaginal fistula. In the previous lecture, we talked about the rectourethral fistula. And today, as you see, there is an abnormal connection between the rectum and the upper vagina over here, and this is what we call it, the rectovaginal fistula. And actually, rectovaginal fistula may be caused by malignant, benign, or iatrogenic causes, and we would see that the diagnosis is based on history and the clinical exam, and we will see that radiological study actually will enhance our diagnosis, will support our diagnosis. It's not routinely mandatory. Here we will see that we will focus in the function of the anal sphincter, as it is a key component for the treatment. Also, we will see that infection, if present, should be treated first, and these principles actually we already discussed it when we talk about the urethral fistula and any fistula, actually even simple fistulas, simple perianal fistulas. If infection present, should be treated first, I mean before the definitive treatment. We will notice also that asymptomatic or minimally symptomatic fistulas may not require treatment, same as the other type of fistulas. We will see that also in Crohn's disease, if the cause is Crohn's disease in rectovaginal fistula, even rectourethral fistula, simple fistula, these in such cases we have to maximize the medical treatment, and we may actually use more conservative method in a treatment, and even what we call it the conservative surgery, such as long-standing sit-on can be applied to avoid a radical type of surgery in Crohn's disease. We will see that our treatment actually is affected or influenced by the etiology of the fistula, the location of the fistula. We will discuss the classification and different approaches that can be used to treat rectovaginal fistula. Also, we talked about the anal sphincter function, and we will see how it will influence and reflected in the treatment of the rectovaginal fistula. Also, if any previous repair attempt, this is primary or recurrent, this also will reflect in my treatment plan. We will see that among of our treatment option is the flap, which we said even in the previous lecture that a well-vascularized, healthy tissue flap can help us in certain approaches in the treatment of rectovaginal fistula, and we showed you that the flap, this is a tissue between the rectum and urethra. In this case will be between the rectum and vagina, and we will discuss the diversity of the flap we will have. And actually we said also of the modality of the treatment is the fecal diversion. In rectourethral fistula we said that urinary diversion and fecal diversion exist. Even urinary diversion is the first step in treating simple fistula. Here we are talking about rectovaginal fistula, so fecal diversion may be required sometime. We will show this, we will see this in the next few minutes. Okay, if we are talking about the definition, what does rectovaginal Fistula means this will take us to the depth in the anatomy of the anal canal, to the anatomy of the cervix, vagina, rectum, and we do not, this is not a lecture of anatomy, it's enough to remember that's abnormal connection between the rectum or anus and the vagina or cervix. And actually, most often this is due to obstetrical, iatrogenic in another word, obstetrical injury or Crohn's disease. Other causes such as infection or the cryptoglandular infection, surgical complication, colorectal surgical complication, radiation as a part of a treatment for malignancy. So malignancy radiation actually exist. Actually, they can be classified according to the location, and here the dentate line plays a role. Below the dentate line, we are talking about from the rectal side and the rectoanal side, so below the dentate line, and from the side of the vagina, we are talking at the level of the vaginal opening or the vaginal fourchette. So this is defined as low, and we will see that low is usually a simple fistula. So distal to the dentate line and at the vaginal fourchette. While high, we are talking above the dentate line, and here we are talking at the upper vagina. If we are talking about the vaginal side, so upper vagina near the cervix and the rectum. If you notice that low is actually an vaginal fistula. So we usually use the term rectovaginal fistula to describe rectovaginal fistula. So the term can be used as a misnomer actually. So we said that high from the upper vagina, we are talking here about the cervix, level of the cervix, and above the dentate line, we are talking about the rectum. We said that simple actually usually low. If we are talking about the diameter, of the opening, less than 2.5 centimeter comes with simple fistulas. And if we are talking about the etiology, so obstetrical injury or infections comes with the simple fistula, whereas high location of the fistula within the rectum and within the cervix, and larger diameter above 2.5 centimeter, and etiologies not related to obstetrical injury and infection, such as radiation, cancer, complication of some pelvic colorectal surgeries or gynecological surgeries. So these are complex. Before moving to the symptoms, I would like to show you this is how we actually classify them according to the location, low and high, according to the size. Here in this literature they classify it to small, medium, large. It's enough to remember that below 2.5 centimeter and above 2.5 centimeter. It's nice to here we have we are not in anatomy lecture, but actually the rectovaginal fistula is a defect in what we call it the rectovaginal septum. So a defect in a rectovaginal septum, what we can add that from practical let's say standpoint or practical wise, some surgeons says that comfortable with classifying fistulas as low and simple if they feel it with digital rectal exam, and if they cannot feel it with digital rectal exam, they may require more imaging and will define it as a complex fistulas. Regarding Okay, this is a continuation. We said that simple, this means obstetrical trauma or infection. Other causes comes with complex causes such as inflammatory Crohn's disease, radiation, cancer, failed prior repair. This is a complex actually. Okay. What else? Complex fistula may also result from complication of surgery. We said that after low anterior resection, for example, as a sequence of anastomotic leak, or after hysterectomy. Also, this is a complex surgery. After hysterectomy, maybe this is a result of unrecognized rectal injury during the index surgery. This is also a classification: simple, complex, simple below 2.5 centimeter, low in location, obstetrical trauma, cryptoglandular infection, whereas complex above 2.5 centimeter, high in location, inflammatory bowel disease, neoplasm, radiation. So if we are talking about the symptoms, so we have typical symptoms that range in severity. These include, actually, we have a connection between the rectum and the vagina, so flatus and stool per vagina actually is one of the symptoms. Dyspareunia, painful sexual intercourse, local skin and mucosal irritation is symptoms that range in severity from mild, moderate to severe. Actually, as we said in the beginning of the lecture, that the evaluation actually depends on history and physical exam. History that will include, of course, past surgical history if we have gynecological lower pelvic surgery, any presenting illness, evidence of inflammatory bowel disease, and physical examination. This may include anoscope, digital rectal exam, vaginoscopy, okay, and also in the history we have to figure out the bowel movement, such as the frequency, consistency, and the ability to defer defecation. In other words, here we have to highlight on the continence and defecation mechanism. Are they normal or affected? And we will see how the sphincter assessment will play a role in the treatment, in our approach in the treatment. Also, the amount of discharge from the vagina also should be assessed. We said imaging is not mandatory, is not routinely, but we may need this imaging modality. We will see if the clinical exam and history is equivalent, does not provide enough information. So sometime, for example, to define the anatomy, fistula, the integrity of the anal sphincter, we may need some diagnostic imaging, manometry to assess the function of the anal sphincter, endoscopy, or examination under anesthesia. Again and again, if infection present, please treat the infection either surgically, antibiotic, ceton, treat the infection. Definitive treatment we have, and you may do not get the imagination that I want to deliver for you now, but you will understand by the end of this lecture that this range, actually we have diversity. It may be, if we said at the beginning of the lecture, if asymptomatic or minimally symptomatic, this does not require treatment. This may the treatment may be only conservative in a form of diet modification, actually. And also, what type of surgery? This depends on, do we have a previous attempt for repair, previous failed attempt, severity of symptoms, is there any healthy tissue to use as a flap? What is the etiology? Is it cryptoglandular infection or radiation or cancer. What is the integrity of the sphincter? Do we have any evidence of fecal incontinence? For example, what is the condition of the rectum? Is we do we have a healthy rectum, or we have a proctitis? We have a stricture. Okay. Also, the vagina, is it healthy? Do we have healthy vaginal epithelium? The treatment of fistulas, actually the surgical treatment, range from rectal resection and or rectal preservation. Rectal resection, for example, and coloanal anastomosis. This can be in staged, a single fashion or a staged fashion. It can be the surgical intervention can be by endorectal advancement flap, which we already discussed it when we talk about simple fistula treatment and when we talk about the treatment of rectourethral fistula. So endorectal or endovaginal flap can be used. Anterior overlapping sphincteroplasty. You may not get what do we mean, but actually here we bring the sphincter as a flap. We will see a picture in the next few minutes. We talked about the pedicled flap, the different type of pedicled flap. Well vascularized, healthy flap can be used. Actually, this is to put a bulk here, bulk between the rectum and the vagina to understand the concept. We actually try to put a bulk of tissue between the rectum and vagina. This is what we mean by the flap technique. Episioproctectomy and reconstruction of the anal sphincter, you will understand it and imagine it and understand the indication in the next few minutes. You have to remember that surgery requires many time in a staged fashion. Success rate is low when we compare single attempt of repair to multiple attempt of repair. So in many cases multiple surgeries required. And remember please that in Crohn's disease infliximab alone may be sufficient. Okay, what else we want to add? Let's talk a little bit about the etiology in details. Okay, if we talk about the etiology in details, so as you see, it may be due to obstetrical injury. We will see how obstetrical injury can cause rectovaginal fistula. Crohn's disease, these are the most common. Obstetrical injury and Crohn's disease. Cryptoglandular infection. Actually, this is the theory behind the perianal abscesses and the fistulas, how they can develop. Complication of colorectal anastomosis or anorectal surgery, malignancy, and radiation therapy. We will discuss this table in details. Just let's review other pictures here. Etiology: obstetrical, fistulizing Crohn's disease, malignancy of the cervix, rectum, uterus, vagina, post-surgery, post-radiation trauma, anorectal separative disease, abscesses, infections such as cytomegalovirus, TB, HIV, okay, congenital fistulas. We are talking about acquired fistulas here. Fecal impaction, pisser usage, long-standing pisser usage. How this is the child coming through his or her mom, and you can see that here we can, in the rectovaginal septum, can develop rectovaginal fistula. Anteriorly we are talking about the VVF or vesicovaginal fistula. You see here that most are due to obstetrical injury. Second degree comes the inflammatory bowel disease or Crohn's, prior surgery, infection, And let's just highlight on the how does childbirth can cause a fistula. Actually, this is maybe due either to prolonged labor or obstetrical injury. If a prolonged labor, we are talking about pressure necrosis of the septum between the vagina and the rectum. Okay, we have different approaches, we will not discuss them here. Now, obstetrical injuries, this is actually usually due to the third or fourth degree perineal tear or episiotomy that is done intentionally during birth. Crohn's disease, let's move a little bit. Cryptoglandular infection, this is, we talked about the abscess and fistulas, and we said that 90% are due to the cryptoglandular infection. These are glands with a crypt in the intersphincteric space. So abscesses actually can be cryptoglandular or the Bartholin cyst infection that can present near the vagina. Also, infection in general, diverticular disease can cause actually rectovaginal fistula. This is a rare cause, yes, I know, but and some of you can says here that diverticula does not exist in the rectum, but actually a proximal rectovaginal fistula can be due to diverticular disease. This is actually due to penetrating infection, and you can see that the repair can be sigmoid resection or vaginal repair. This is actually proximal type of fistula. Crohn's disease, we know that we have an entity called fistulizing perianal Crohn's disease, which cause penetrating infection, which usually distal, and here you can see that the approach depends on the sphincter integrity. Do we have a sphincter injury or not? Complication of colorectal, coloanal surgery, such as if we did low anterior resection, ileal pouch, anal anastomosis, hysterectomy. Actually, here we are talking about anastomotic complication, and this depends, are they proximal or distal, and we have variety of options to treat them. Complication of coloanal, colorectal surgeries. Malignancy and radiation. How can malignancy and radiation cause? Malignancy by direct extension of the tumor. Of course, here malignancy of the rectum, cervix, vagina. If we are talking about radiation, this is due to chronic tissue damage, and we would see the diversity of treatment. If we highlight on the obstetrical cause, it's over here, I think, obstetrical cause. What we can add regarding the obstetrical injury more than what we talked about, we just want to highlight on the rectovaginal septum and the importance of the rectovaginal septum. Actually, it exists over here. I have no image now. As I said, this is not an anatomy lecture, but it is actually a thin septum separating the anterior rectal wall and the posterior vaginal wall. The caudal portion will be the perineal body, and it is anterior to the sphincters. What we can add regarding the obstetrical injury, that there are actually 2 or 3 mechanisms. First of all, we said if we have prolonged labor, so pressure necrosis to the rectovaginal septum, or it may be due to the laceration of the sphincter complex during delivery, or due to episiotomy, and maybe due to unrecognized rectal injury. Unrecognized rectal injury, here we are talking about not only childbirth, but maybe more advanced gynecological surgery. What I want to add, if we identify the cause, during the surgery, during the childbirth, for example, during delivery, for example. So it's ideally to do immediate repair of the fistula, of the sphincter injury, of the septum, to repair the septum itself. So it's ideally to immediately repair, but actually this is maybe limited by the absence of experienced surgeon that can do such repair. Crohn's disease. Okay, regarding Crohn's disease, as you see, the risk of developing rectovaginal fistula in female who have Crohn's disease is up to 1%, which is significantly high. And we will see that most of them present initially as simple perineal fistula or perianal fistula. The risk over 10 year, or what we call it cumulative risk, is 3%, which actually high. The incidence of fistulas in general and rectovaginal fistula have decreased since the invention of the biological treatments. We discussed that when we talk about Crohn's disease. We said that anal fistula may be the initial manifestation, and then after proper assessment, after time, we will find that this is a rectovaginal fistula. First step in the treatment, this will be controlling the infection, the sepsis. This will include incision and drainage, ceton, and we have a concept, long-standing ceton or lifelong ceton, antibiotic, self-care. Okay. Actually, the extent of the disease should be assessed with examination of the rectum and anus via anoscopy, proctoscopy, and this is better to be done under sedation. This actually will give us the comfort for the patient and the surgeon. Also assessing if there is proctitis, infection or inflammation of the rectum, because this will affect the treatment plan and the prognosis. Assessing the if there is any rectal structure, any anal structure, any associated perianal fistula. This should be done during the evaluation of fistula in a Crohn's patient. MRI, it's the best imaging modality that is not mandatory, but the most useful imaging modality. We use it selectively when the history exam with anoscopy, digital exam, rectal exam is not sufficient. We said controlling the sepsis, controlling the infection. This can be done with severity of options. Even those with no or minimal symptoms does not require no medical and even surgical procedure. We here should highlight the importance of infliximab. We know that it is anti-tumor necrosis factor, which is effective. Actually, if you want to review the study regarding the effect of infliximab in Crohn's disease and rectovaginal fistula, the success rate of healing varies. The conclusion that it's worth to try it, but it is not a panacea. It is not the definite solution, but no problem to try it. Okay, promising results from stem cell injection. Actually, we think in the next 20 years we may see that stem cell injection in the fistula can heal. So stem cell treatment. Surgery, actually, you have to remember that surgery is not contraindicated. Actually, it's actually not preferred, relative contraindicated. So surgery is similar to non-Crohn's disease, but actually the failure rate is higher. Here we have a range of treatment from draining seton up to proctectomy and permanent stoma. Between these two options, between seton and proctectomy and permanent stoma, we have the endorectal advancement flap, the gracilis puborectalis or Martinius flap, rectal resection, coloanal anastomosis. These are not absolute contraindication, but we can say relatedly failure rate is higher in Crohn's disease. As we said, the success rate of surgical treatment is lower when we compare it, as you see here, the overall success in one study shows that in Crohn's disease is 44, while up to 80 in non-Crohn's disease. Also, again, majority will heal after multiple attempts, different approach for repair, same as non-Crohn's rectovaginal fistula. Again, a question exists: do the medical treatment augment, synergize, help in my surgical treatment? What we know that it does not negatively affect. Does it positively affect? We are not sure. For example, the use of infliximab, the use of steroid, immunomodulator, do they help before the surgical treatment? It does not, or they does not negatively affect, but we are not sure if they synergize the result. We have a concept of temporary fecal diversion, especially in patients who have previous failed surgical attempt, redo surgery, in patients who are technically challengeable to treat fistulas. We are talking about complex fistula, and we have suboptimal tissue condition, in another word, proctitis or bad flap to bring for interpositioning. Risk factor for permanent stoma is fecal incontinence, usage of temporary fecal diversion is a risk factor for permanent stoma. Complex fistula, by definition, these are complex fistula, so Crohn's rectovaginal fistula is a risk factor for permanent stoma. What else I can add? History of rectal resection, anal stricture and stenosis. These are risk factor for that push us toward permanent stoma. So permanent stoma exists as a modality of treatment in rectovaginal fistula in patients with Crohn's disease. If we want to highlight in the cryptoglandular cause, cryptoglandular actually cause, we already said that cryptoglandular as a cause for rectovaginal fistula, it's not that common. Actually, cryptoglandular theory or cryptoglandular abscesses explain 80 to 90% of fistulas and abscesses that occur in the anal, perianal region. And these actually glands with the crypts that transverse the sphincter, the intersphincteric space. As you see here, they are less common as a cause for rectovaginal fistula, and the treatment begin with eradication of sepsis, of abscesses if present. We have to incise and drain. We have to, if antibiotic in a form of eradication of sepsis is what option I have, incision and drainage, antibiotic, and I may use ceton for drainage of the sepsis, and then I will go to definitive treatment, and this actually should be individualized. I do not need actually definitive treatment if the patient have minimal symptoms or asymptomatic. Also, this depends on the sphincter integrity. If the patient have fecal incontinence or not, you will recognize or understand what I'm talking about in the next few minutes when we review the approaches. And the condition of the surrounding tissue, if I have, can I use well vascularized good healthy tissue as a flap, for example. If we are talking about surgeries or rectal anal surgeries in the pelvis, so appear here the anastomotic complication, for example, colorectal or coloanal anastomotic leak, which can develop to rectovaginal fistula, and you can see that anastomotic complication can develop in 10% to fistula to vaginal, which is a large number. And first option here is to go for fecal diversion. You have to temporarily fecally divert the stool, and actually you have to remember that there is a good number of patients that will heal alone with just fecal diversion with no surgeries in the fistula. So if the symptom persists or the fistula persists, depending on my physical exam, on my imaging, so I have to consider neocolorectal anastomosis, redo surgery, do new coloanal anastomosis, endorectal advancement flap. We already showed you what does endorectal advancement flap means, and gluteal fold flap interposition. These are as actually, if I have anastomotic leak and the patient does not heal with fecal diversion, I think of this, for example, 3 options to understand what does gluteal fold interposition flap. This is a picture, and permit me not to use an extremely sensitive picture because I used to publish these videos in my own Facebook page and on YouTube. So this is the gluteal fold flap interposition. Other causes of anal surgery that may cause rectovaginal fistula is the stable technique for hemorrhoidopexy or rectal resection. And when we discuss, this is how we can use a stapled for hemorrhoidopexy or rectal resection. When we discuss these modalities, we said that these modalities should be done by an experienced colorectal surgeon. And when we talk about radiation for rectovaginal, the same principles for rectourethral fistula. And we said that these fistula may present up to 15-20 years after the last dose of radiation. So, as you see, from 5 months to 20 years, of course, here radiation we are talking about, for example, treatment of cervical cancer, of rectal cancer, pelvic malignancy. So treatment starts with fecal diversion. We have other options for treating radiation-induced rectovaginal fistula. Actually, we have a good success rate, such as pulpocavernous or pulpocavernous. You will get it. What do we mean by that? Or rectal resection and coloanal anastomosis. We briefly talked about the evaluation of the patient with rectovaginal fistula when we said that we depends on history, proper history, and clinical exam, including anoscopy and imaging. Actually, these are additionally, these are not mandatory, not routine. And of them we said that MRI is the best to figure, for example, fistula in cases of Crohn's disease. But what we else want to add regarding the evaluation of rectovaginal fistula? Okay, let's see what we can add. We begin with history, we focus on the duration of the symptoms, nature, volume of the vaginal discharge, number and consistency of day and night bowel movement, ability to differ defecation and flatus, evidence of fecal continence. And here you have to focus, is this a true fecal incontinence or this is a vaginal discharge? And it's actually hard to determine this is vaginal discharge or true fecal incontinence, but these patients have fecal incontinence higher than normal population, and this actually direct us toward assessing the sphincter function. Usage of pads, how many pads the woman used to control the discharge. So usage of pad and number of pads per day. This will actually highlight the amount of drainage from the fistula. Actually, if I have feces, not drain, not discharge, this is more likely to be associated with diarrhea. Presence of urinary symptoms, and here we start. If we have urinary symptoms, we have to ask ourselves, is this a coexisting recto-urethral fistula or rectovesical fistula, or it is an ascending infection from the vagina? We said we have vaginitis, so can be an ascending infection. So presence of urinary complication such as nematuria, fecaluria, past medical, past surgical history, we can actually signify the importance of each one according to the etiology of the rectovaginal fistula. Childbirth, if there is a previous attempt of repair. So awake, we start with awake exam. Actually, examination under sedation, we will see if we have no sufficient information from awake exam, we go to exam under anesthesia. We start with inspection of the anoperineal region, including digital rectal exam. We may feel the tract, by the way. There will be a fibrous cord or the defect in the anterior vaginal wall. Okay, digital rectal exam and also PV. We will talk about the importance of PV. We have to assess the integrity of the perineal body, and actually this is the space between the anus and the vagina. The perineal body is a separate entity. If it is weak or the septum is thin, more likely to be associated with fistula. If there is any scar, episiotomy, sphincter laceration. Also we assess external and internal sphincter. We can assess them by the sphincter tone on digital rectal exam. If needed, we can proceed to endoluminal ultrasound or anal manometry. The size and location of the rectovaginal fistula. Vaginoscopy and anoproctoscopy. Actually, anoproctoscopy will give us the to be honest, vaginoscopy is the best modality, but as a colorectal surgeon, we focus on the anoproctoscopy. Vaginoscopy have a higher sensitivity. In these two instruments, I will show it to you, we focus on the location, size, structure, if there is proctitis, anemicosal abnormality. This is the episiotomy. You see how it could be done. Just to imagine what do we mean by episiotomy and how the close relationship between the vagina and the anus. This is the anoscope, this is the vaginoscope. We said vaginoscopy is better. Okay, let's move a little bit. If awake exam does not fail, we can proceed to examination under anesthesia. We have a concept which is selectively, it's not mandatory to use it. We call it the tampon test. Actually, as you see in this picture, it's a tampon. Actually, this picture, we have a fistula between the urinary bladder and the actually cervix or the upper vagina. Here we can have if we just, this is an imaginary photo, if we have a fistula between the rectum and the vagina, actually we can actually the tampon will get stained with feces or a modified type of it. As you see in this picture, we can instill 50 cc diluted betadine stain and see if there is a staining in the vaginal tampon. This will actually help us in the diagnosis. So, as we said, a tampon or gauze in the vagina inserted by the patient himself, herself, leave for several hours, then we inspect for fecal staining. A modification, this when we add the stain. Okay, this is selectively again. Also, selectively, we can use diagnostic imaging. We said these are good to define the anatomy of the fistula, number of tracts, if there is any concomitant fluid, abscesses, collections, underlying pathology can be figured out. MRI is the preferred modality. We can use CT, but MRI is superior. Fluoroscopic study can be used also additionally if I need additional information. We can use vaginography or rectal enema contrast, especially in cases of colorectal anastomosis if we suspect the leak. Again here, vaginography have higher sensitivity. I think I have. This is an MRI. You can see the rectovaginal septum over here. This is the rectum, this is the vagina, this is the rectovaginal septum, which looks nice here. This is a vaginography which shows a fistula. I doubt that you can figure it out, nor me, but this is a vaginography. And what else we can add about the evaluation of these patients? In the luminal ultrasound, we know that in the luminal ultrasound is good to assess if there if there is fistula and to assess the sphincter integrity. But actually here we are talking about septum, higher fistula a little bit, so it's not the first line imaging study. It can assess the sphincter. Endoscopy in a form of proctoscope, colonoscope, colonoscopy, sigmoidoscopy, should be considered in patients with Crohn's disease, for example, radiation-induced injury. Again, counseling and asking for help from the gynecologist and urologist if we have pre-existing or coexisting rectourethral fistula. If I'm planning to do surgery with fecal divergence, so pre-op marking and education about the fistula is mandatory. What else we can add? Presentation, actually present as a stool or air per vagina. Here I want to say that most rectovaginal fistula are symptomatic, not asymptomatic. So stool or air per vagina, foul smelling and vaginal discharge with recurrent vaginitis and urinary tract infection. The urinary tract infection not because of rectourethral fistula, but of the ascending infection that can be happened. You can see here that incontinence up to 50%, and we do not know this is actually a true fecal incontinence or it's from the vaginal discharge. Of course, if I have from the history diarrhea, abdominal pain, mucus discharge, so I have to focus on the inflammatory bowel disease. This is episiotomy, this is anoscopy, vaginoscopy, this is the tampon test we talked about, and again, this is how the PR, digital rectal exam, clearly identify the fistula. Some literature says imaging usually required for high fistula, complex fistula, while low fistula doesn't require. Entire rectovaginal septum should be assessed. Actually, this is when I said the importance of PV or per vaginal exam. Actually, you have to put your two finger and feel even the thickness of the rectovaginal septum. So entire rectovaginal septum should be assessed. I mean, one finger through the rectum, the other in the vagina. Significant scarring, tissue, stenosis. What else? Lower rectovaginal fistula are easy to visualize and palpate and you can feel a dimple or fibrous-like, cord-like in the anterior midline on the digital rectal exam. We can use a probe. We will see when we talk about the management. This is examination with one finger in the rectum and one finger in the vagina to assess the bulk of the rectovaginal septum and assess the perineal body. If it is attenuated or absent, this is associated with obstetrical injury, which will lead to rectovaginal septum. The use of barium enema here is limited. We said vaginography we can use recto enema in the rectum that will lead to the vagina. Okay, tampon test we talked about it. Some will actually watery instale the vagina and insufflate air in the rectum and see if there is any bubble in the vagina. Okay, this is the imaging, this is the vaginography, they talk about the transrectal ultrasound and the usage. Usually when we use ultrasound imaging for fistula, we use hydrogen peroxide. Vaginography and MRI may also help. Okay, what else we can add? Here, this is imaging study are more useful in mid or high fistula. Low fistula usually straightforward and you can detect them and assess them. Assessment of the anal sphincter is important. I actually use many sources so to create a clear imagination about the subject. What else written here? We said that few are asymptomatic. Most patients have symptoms. Vaginitis, cystitis, foul-smelling vaginal discharge, frank stool per vagina. This is associated with diarrhea. Okay. Let's move to the surgical technique and surgical approach, our lovely parts. And regarding the surgical technique, actually this will lead us to talk about the approach. How I can reach the fistula, through the vagina, through the rectum, or through the perineum. And or abdominal approach also. Okay, and apologize me, this is a little bit sensitive photo. I crop it as much as I can. These are probe, one from the vagina to the perineal region, another from the perineal defect to the rectum, and one here as you see coming from the vagina to the rectum. This is the perineum. So what will determine my approach? Actually, first of all, we have to remember that we preferred the natural orifices, the rectum or vagina, to enter, because if we have an incision through the perineal region, it's first of all carries a high morbidity, and even some surgeons do not repair it. They leave it for secondary intention to close. It's painful, so it's not the preferred one. So especially if I have distal fistula in the anus, in the anovaginal, rectovaginal, it's preferred to enter through the rectum or vagina. We will see which is better. So we avoid trauma to the perineum. Okay, when perineal approach is preferred, it's preferred when I have sphincter injury, for example, incontinence. I don't want to enter the rectum through the stretching to the rectum may worsen the condition. If I have gapping introitus, wide vagina, again, I don't want to enter the vagina and make the problem worse. So in these cases, we prefer the perineal approach. Also, if I have perineal body or perineal tissue deficit, I can enter through it and repair it later. So, what's the preferred? We said we prefer the natural orifices, rectum, vagina. Unless there is rectal widening, vaginal widening, anal widening. What we prefer, actually, because we are a colorectal surgeon, we prefer the transrectal or transanal approach. This is because we have more experience, and there is a philosophy says that repairing the high pressure area is the priority, and here the high pressure area is the rectum, but actually this may actually push us toward the transanal approach or transrectal approach. Okay, in some cases we avoid the anal sphincter stretching with retracted, so we preferred the transvaginal approach. If we have, for example, history of incontinence, problem in the sphincter, so we prefer the transvaginal approach. Of the consideration pre-op, of course, we are dealing with fistula and incision, so smoking cessation, weight loss, diabetic control, improved bowel wall consistency and frequency is important. Okay, some surgeon do bowel prep and other prefer enemas. It's a little bit controversial. What we know that we need also single dose antibiotic. Okay, what post-op? I think there's no superior technique for one over the another. All of these technique actually carries a failure rate, and also the healing rate between 50 to 85. This is good. Also, we have to discuss the possibility. We have to discuss with the patient about the possibility of post-op dyspareunia and change in bowel function, which actually frequently present after treatment and should be discussed, and actually the quality of life is altered frequently after the treatment. Or the complication, bleeding, infection, sepsis. We said that the perineal region also breakdown of the perineal skin, so some surgeons prefer not to close it and leave it for secondary intention. Drain are surgeon dependent. Vaginal packing after surgery, it's selective, help for hemostasis. We can discharge the patient the next day with no diet modification, actually, some stool softener, and actually we prefer the patient to what we call it the peripotal or handheld shower. When we compare it to the tube soaking, we avoid tube soaking. This is what we mean by actually peripotal wash. This is after we discharge the patient, and we actually restrict the patient from sexual activity, tampon use, excessive leg stretching, strenuous activity for 6 weeks. Before we review the approaches, or why not, actually we have, you see the approach, we said that we have the perineal approach. We will talk about the two modality that we will discuss. These are episioproctectomy or transverse perineal repair. We have the transrectal approach, and we will talk about the rectal sleeve advancement. We have the vaginal approach. We talked about vaginal, transrectal, perineal, abdominal approach, and we will talk about some tissue transposition repair, how to use flap and some prosthetic product which are usually used as adjunct. What else I can want to add? Let's review some slides. For example, the treatment here, they said that depends on many factors, including the site of the fistula, cause of fistula, surgeon experience, and the presence of associated sphincter defect and incontinence. We said in cases of incontinence, we avoid the anal or rectal approach. Okay, what else we can? Quality of life and sexual function following the repair of rectovaginal fistula are frequently reported, so the patient should be counseled well. Although the mainstay of treatment for the majority of rectovaginal fistula is surgery, there are few exceptions. We said not all minimally symptomatic or asymptomatic does not require surgery. You see, small number of fistulas may close spontaneously, especially after obstetric trauma. Hypertonic oxygen, we do not review it when we talk about the approaches. Hypertonic oxygen also reported in the literature as a treatment modality for rectovaginal fistula. We know that hypertonic oxygen can assist in the healing of a small fistula, especially. We talk about the immunomodulatory treatment, especially in Crohn's, infliximab, and what else? They in this slide they support. We said that medical treatment we should be maximized in Crohn's disease, such as infliximab, etc. Here we said that it does not negatively impact on the surgical treatment. Here they says that it is positively impact. So they support the medical treatment that synergize, that augment, that enforce our success in surgical treatment. We said all procedures have significant failure rate regardless of the approach. Cigarette smoking should be stopped. Quality of life assessment, including dyspareunia, should be discussed with the patient. Timing of surgery, controversial. We said if detected, for example, while delivery, immediate repair if available, if surgeon experience permit. So it's controversial to do immediate repair versus with secondary repair or delayed repair. If recognized at time of delivery, initial repair is preferred at the time of delivery by the obstetrician, but some obstetrician doesn't have the experience to do that. Okay, here they actually advise if delayed repair to wait for 3 months after obstetrical delivery or childbirth to give the tissue time to decrease the inflammation and swelling that can happen. Okay, what else we can add? If we have repair and failed, please wait 3 to 6 months. Again, this is to decrease the tissue swelling and the tissue inflammation that may happen. These are the approaches we have. We talked about the abdominal approach, the tissue transposition, when we talked about the flap, and the hypertonic oxygen. Tissue transposition, we will talk about it. We have the pulpocavernous, gluteus muscle, gracilis. We, in the beginning of the lecture, talked about the gluteus fold flap, sartorius, pudendal thigh. Others, they said the hypertonic oxygen, infliximab, and other biologic for Crohn's disease. Abdominal approach, when we talk about abdominal approach, we are talking about complex, high fistula and radical treatment, aggressive treatment in a form of low anterior resection, coloanal anastomosis, patches, APR, fecal diversion. These are abdominal. And when we talk about the local repair, they mean the transanal, transvaginal, perineal approach. We will see that the transanal, we can do advancement flap, sleeve flap, etc. We will review each approach separately. What else we can add? Okay, let's talk about the perineal approach. Okay, the perineal approach, and if you remember, we said we prefer perineal approach if we have concomitant associated sphincter injury, if we have fecal incontinence related to sphincter injury, if we have large or gapping enteroitus, large vagina, widening of the vaginal opening, if we have perineal injury. So we are capable to repair the sphincter complex. We are capable to repair the vaginal mucosa and opening. We are capable to repair the perineal injury if it exists, and we said that we prefer the natural orifices, the rectum or vagina, if the sphincter are normal. And one of the disadvantage of the perineal approach, that the perineal incision carries a high morbidity, so we avoid it. We said perineal approach preferred in anal sphincter injury, deficient perineal tissue, gapping enteroitus. We are capable to repair them, and also if I use transrectal approach through the with an anal sphincter injury, this will actually worsen the condition. Again, if I use transvaginal approach in a gapping enteroitus, this will worsen actually the condition. Regarding the transperineal approach, actually we have two operations that are similar to each other. The first is the episioproctotomy, and the second is the transverse perineal repair. Actually, one is opening over a probe, other is opening transversely over the transverse perineal muscle, so it will look like a longitudinal incision. To understand what I'm talking about, this is actually episioproctotomy. This is an opening over a probe, so we induce a fourth degree injury, actually a fourth degree perineal injury. This is actually a flap done from the external anal sphincter, and we close it in an overlapping technique. This may actually tighten the sphincter injury that may be concomitant with this approach. We said that if transverse perineal injury is preferred if we have sphincter or perineal injury, so overlapping may also help, and we are capable to do this overlapping with mobilization through the perineal approach. Okay, other perineal approach is this transverse perineal approach. Actually, this is the transverse muscle. Transverse over it, we will cut over here. So many muscles will be cut. Actually, the transverse perineal muscle will be cutted, external anal sphincter, the pulpocavernous muscle, and all of these should be repaired. And if we go deep, we will find the rectovaginal septum and the fistula tract. We need to cut the fistula tract. Any granulation tissue should be removed. As you see here, for example, we have this is the pulpocavernous muscle, this is a tear in the transverse perineal muscle, and this is part of the external anal sphincter. We should repair them and finally repair the vaginal hymen. Actually, we said if we have a gaping enteroitus, we can do some tightening through this approach. If we have fecal incontinence or sphincter injury, we can repair it through this approach. But I want to add, actually I don't want to disturb you, the transperineal approach, the two different technically different mechanism, the transverse perineal repair and episioproctotomy, they are similar to each other actually. Closure should be by layer. We should identify the anatomy well, the pulpocavernous, the transverse muscle, the external anal sphincter should be identified. These patients are in lithotomy or prone position. We said again and again, perineal approach for female with a sphincter or perineal injury. I understand it for two reasons, not one reason. First, because I'm capable to repair the sphincter and the perineal muscle through this approach. Second, if I go to transrectal approach with a patient with a sphincter or perineal injury, I will worsen the condition. Do you get it? So what I can add, we said through the episioproctotomy, we do a flap for the external anal sphincter and we close it in an overlap technique. We said that the fistula tract should be excised and debrided if there is any vaginal, any granulation tissue. Actually, the skin as a last step, some surgeon leave it open, the skin over here, some surgeon leave it open to heal with secondary intention, or loosely approximated. The rectal mucosa is closed with absorbable suture, preferably with a 3O, and also the vaginal mucosa is approximated with a 3O absorbable. Be caution when you start to repair the hymenal edge. This is the hymen edge. You may even do tightening if you have widening in the vaginal opening. You may do tightening. So this is regarding the perineal approach. Let's transverse perineal approach. What else we said in transverse perineal approach? An incision from the vagina to the anus. What's different? They are similar to each other technique. Closure the rectum. It's preferred to close the rectum with absorbable suture in a 2-layer. Okay. Regarding the transrectal approach, transrectal approach, actually we have two approaches or two technique. The first that is the endorectal advancement flap, which we are familiar with it. We talk about it when we talk about treatment of anal fistulas, treatment of endorectal treatment of rectourethral fistula, and also in rectovaginal fistula. We need first of all, or prerequisites for this operation, a healthy rectum. We will see that if diseased rectum, such as in Crohn's disease or radiation proctitis or previous failed attempt, we are talking about other technique. And also this is indicated, or the most commonly performed, the endorectal advancement flap, or sometimes they call it the sliding flap repair. This is performed if no sphincter injury exists. If sphincter injury exists, so we are thinking of perineal approach. Okay, so sometimes they call it the sliding flap technique. The principles is easy. We do a flap, as you see, it is rhomboid shape, as you see here. Where is it? This is the shape. Actually, the length of the flap should be more than half of the base of the flap. This is to avoid any tension. You see how it looks like. The dissection goes through the mucosa, submucosa, and even part of the internal anal sphincter. We identify the tract, we debride it, we may remove the fistula and close the opening, and as you see, we pull finally the flap and we close it. What else I can add about this technique? Okay, let's see. Endorectal advanced flap. Why it's most common? Because we are, as a colorectal surgeon, familiar with the transanal approach. Everything here we already discussed. If we have a diseased distal rectum, for example in Crohn's disease, radiation-induced rectovaginal fistula, previous failed attempt, so we move to a more radical option. This is the rectal sleeve advancement. Simple concept. It's not a simple surgery. Simply to understand, actually it is we do a mucosectomy circumferentially up to until we reach a healthy rectum. Okay, and we pull the rectum through the anal canal, as you see in this picture, and we suture it. We will have a new dentate line. This is indicated in case of chronic proctitis, radiation proctitis, radiation-induced rectovaginal fistula, in cases of previous failed attempt. And again, this is a radical surgery. We think of this surgery only if all other surgeries failed, only if my next step is to do proctectomy, if my next step is to do a permanent fecal diversion. So it's a step before permanent fecal diversion. It's a step before proctectomy. You can see this is a fistula. Why we do not repair it with endorectal advancement flap? Maybe this is because of Crohn's. Maybe this is because of radiation. They are more complex. No healthy tissue. Healthy tissue is mandatory for flap technique, for endorectal advancement flap, or sometimes they call it the sliding flap technique. What can we else? Rectal sleeve advancement. We already talked about that. As you see, considered it in patient where only the option is total proctocolectomy or permanent fecal diversion. So it's a step before proctectomy and fecal diversion. If we go to this is the rectal sleeve advancement, we move to the transvaginal approach or vaginal approach. Okay, the transvaginal approach, actually it's similar technically to the endorectal advancement or the transrectal advancement. It's a flap. We identify the fistula, we close it, and we bring a flap, but we are working from the vaginal side. Of its advantages that it eliminate or avoid stretching to the sphincter you see in the transanal or transrectal approach. This is one of its advantage. Also, one of the advantages that it is wider, better exposure. It's preferred in patient with Crohn's disease. Yes, we discuss that in patient with Crohn's disease and no other solution except of permanent fecal diversion, we have to proceed to rectal sleeve advancement. But before that, we may think of the vaginal approach, because patient with Crohn's disease, patient with radiation proctitis, we may work in the vaginal side. Some old literature says that it's preferred to work on the high pressure zone. Here, if we compare the rectum and vagina, of course the rectum will be the high pressure zone. It's preferred to work here, but actually the flap from the vaginal side and the flap from the rectal side actually have the same outcome. Again, okay, what else we can add regarding one of the indication, if I have a fistula not between the rectum but between the pouch we created, for example, ileal pouch, anal anastomosis, we create a pouch after proctectomy, and we have a fistula between the vagina and the pouch called the pouch vaginal fistula. So it's preferred to work from the vaginal side. It's the least common actually, because we as a colorectal surgeon prefer or familiar with the transanal approach. Some technique through the vagina are flapless with no flap. It's just coring out the fistula and debridement of any granulation tissue and closure of the fistula. As you see, of the advantage, we avoid extensive mobilization of the diseased rectum and sphincter stretch. We avoid sphincter stretch with the retractors that we use through the rectum. Technically, it is the same, and it's preferred in patients with Crohn's disease. Regarding the tissue transposition, okay, tissue transposition for rectovaginal fistula, and unfortunately, you will not find this clear guideline that will help you in when to use them or not, but actually as a general rule, for more complicated than the previously mentioned fistulas, such as those who have prior failed attempt, actually we use the transposition flap or the transposition tissue to decrease the dead space, to enhance the strength of the septorectal or rectovaginal septum, such as previous failed attempt, Crohn's disease. In radiation-induced rectovaginal fistula, we use tissue transposition. Repair, actually, we will see that this consists of tissue, fat and muscle, and we need, of course, a healthy, well vascularized flap. They are a type of pedicled flap that will increase the bulk of the septum and decrease the disk space. Actually, we have two main tissue transposition repair. These are the Martius and gracilis flap. I think we talk about gracilis flap in detail, and even the technique when we talk about the rectourethral. About the Martius flap, or it is the pulpocavernous sometime, or some literatures call it the pulpocavernous flap, to recognize what we are talking about. Actually, this is the pulpocavernous, and incision is done actually near the vaginal opening to expose the tissue that exists. Actually, I don't know if it is clear or how to do zoom in. Actually, this is the fistula in the vagina and extend to the anus. What we do, we bring a little bit of the fat and part of the pulpocavernous muscle, which should exist here, and we tunnel it. You see here the fistula, you can see the the fat through the fistula. We put it underneath the fistula opening and we close the opening. This is what we call it the Martius or the martius or pulpocavernous muscle flap. Okay, gracilis muscle flap, it's actually, we discuss, actually, I'm trying to use pictures that are not extremely sensitive. Here is the gracilis muscle, we harvest it, we rotate it after doing tunneling, and we position it near the rectovaginal septum, again, to enhance, to synergize, to enforce the rectovaginal septum, and to decrease the dead space. Here, advantages over the pulpocavernous or martius flap, that we have muscle bulk, good muscle, so greater bulk of muscle. Of course, here we have to be careful of the blood supply to each flap. For example, in the martius flap, we have vascular pedicle, which comes from the internal iliac, should be preserved. Here, I think the vascular pedicle come proximal in the thigh and should be preserved. It's from the femoral artery. Okay, these are the two options of the transposition flap. We said martius or pulpocavernous flap and gracilis flap. No clear indication, but we can say for more complicated Crohn's, radiation, previous failed attempt, it is advisable. Okay, radiation induced. Let's move to another technique, which we call it the bioprosthetic product, and we will see that we may use this as an adjunct. And the talk about the bioprosthetic product is actually limited. It's not the mainstay treatment. It's usually used to enforce other treatment, other surgical modality. As an adjunct, we have many options. The bioprosthetic product, actually, they enhance the scar formation. Actually, success rate is low, and if you remember in the beginning of this lecture, we talked about the stem cell injection, and we said that it is promising, but I don't know if it failed under the bioprosthetic product. I think it's biological product, the stem cell, for example, the stem cell injection for fistula. Bioprosthetic product, for example, the fibrin glue, which here the advice for long tract rectovaginal fistula, the collagen plug. I have no picture, but it's a plug or button, rectovaginal fistula button. All of these have a higher fail rate. They are used usually as an adjunct with other modality. If we want to talk about the last approach, or the abdominal approach, okay, the transabdominal approach, here we are talking about more radical surgery, sleeve surgery, previous attempt failed, extremely diseased rectum due to radiation, due to Crohn's. Here we start to think of abdominal approach. Actually, one of the abdominal approaches that is similar to the approach we discussed when we talk about rectourethral fistula. It's actually if we have a high fistula between the rectum and vagina. Yes, this picture actually shows the rectourethral fistula, but the same principle. You can imagine the bladder and urethra as the uterus and the vagina. Actually, we repair through the abdomen the high fistula. We cut the fistula tract and repair the defect in the rectum. We repair the defect in the vagina, upper vagina or cervix, and we interpose or put the omentum, a healthy omentum, well vascularized omentum, between the uterus and the rectum, between the vagina and the rectum at the rectovaginal septum to enforce it. Actually, this is a pedicled flap and depends on the left gastroepiploic artery. Other solutions is to remove the rectum and to do rectoanal anastomosis. This can be done immediately or in a stage such as in a thrumpal procedure. Thrumpal procedure actually it's bringing the deceased rectum through the anus, and for example, if we are talking about a 3 stage, we wrap it with gauze, and after 5 days, we amputate the prolapsed rectum and we do coloanal anastomosis. Of course, this is in the presence of diverting ileostomy or colostomy, and we then, after checking that our anastomosis is good, we can close the stoma. It can be done in 1 stage, 2 stage, 3 stages. It's not the idea for that. Of course, we can go for permanent colostomy or permanent ileostomy. For example, patient who cannot tolerate this surgery, for patients who have poor medical condition. So these are the transabdominal approach, as we said, can be delayed or immediate anastomosis. If delayed, we are talking about the thrumpal procedure. We will talk in details about thrumpal procedure when we talk about proctectomy actually. What else we can add about the abdominal approach? These are preferred for fistula that are high, proximal, complex, severely damaged tissue such as post-surgery, previous failed surgery, radiation, high fistula. Okay, what else? Okay, here is just a table shows you a simple summary. Actually, I do not rely on them because actually, for example, here after rectovaginal fistula, they assess history, physical exam, anal manometry, endoluminal ultrasound. If we have deficit in the anal function, fecal continence, sphincter complex injury, so we said the transperineal perineal approach is the preferred because we can actually repair the sphincter. If it's normal, we can go through the endorectal advancement flap. This is another also table shows you the obstetrical injury. We said immediate repair if available is a good solution. Delayed repair, okay, if it is recognized, so please wait a little. If it's recognized after surgery, so please wait for 2-3 months until the tissue inflammation and edema subsided, and you can proceed for primary repair or local repair with advancement flap, sphincteroplasty. We talk about the role of overlapping sphincteroplasty. If we have recurrence, we start to think about tissue interposition. We talk about the pulpocavernous and the gracilis interposition. The pull-through procedure, we just talk about the thrumpal procedure or the diverting stoma as a last resort, permanent diverting stoma. In Crohn's disease, they just focus on how medical treatment is important and the usage of ceton actually. Ceton, we talked about the usage of ceton, maximizing a medical treatment including infliximab, and also there is a rule for the muscle interposition, for ceton, proctectomy as a last resort. And here we reach the end of our lecture. I hope I delivered the most important information for you. Goodbye.